Presentation of dialogue on Idaho Public Television is made possible through the generous support of the Laura Moore Cunningham Foundation, committed to fulfilling the Moore family's legacy of building the great state of Idaho.
We spend more than $2.5 trillion on health care in America, yet we rank 37th in the world in health care outcome. Why is America's health care system broken, and what should we do to heal it? Find out. Dialogue is next. Hello, I'm Joan Cartan-Hansen. Thank you for joining us here on Idaho Public Television, on the World Wide Web, and on public radio stations. The Supreme Court's ruling on the Affordable Health Care Act was not the final word on America's health care woes. Many contend we need to rethink our entire approach on how we deliver health care. In his book, Fractured, Boise family physician Dr. Ted Epperly proposes a new strategy to heal America's health care system. Dr. Epperly is the chairman of the American Academy of Family Physicians, and he joins me now. Sir, thank you for being here. I appreciate it.
Good to be here.
And let's jump right into this. You contend that the America's healthcare system is broken because it treats illness rather than promoting wellness. Could you go into that for us?
Absolutely. Our focus is on the back end of medicine, which is disease and sickness, as opposed to the front end of medicine, Joan, which is health and wellness. It'd kind of be like having a fire department. We've got the biggest fire trucks in the world, and we have really good fire hoses, and we can put out a fire at 100 yards. But nobody's really asking the question about prevention of fires. How we can keep those fires from becoming larger. And really our healthcare system mimics that. We go after where the money is, and where the money is in healthcare, or actually sickness care, is in treating diseases and doing procedures and seeing things in volume. And it's not the prevention of those things. We pay thousands of dollars, if you will, for strokes and myocardial infarctions and amputations, but we pay pennies on the dollars to prevent them in the first place.
Can we run a parallel system where we have money for preventative care and a focus on patient-centered care, but still have that fire hose to handle the cancers and the heart disease and the very serious illnesses?
Absolutely. It's all kind of an alignment of incentives and finances, really. If we start to really refocus what we're trying to accomplish, which is to keep people healthy, to keep people from needing to use those things, and actually start to pay for those in a way that keeps health front and foremost, then we will do just that. And so it's kind of a rebalancing, if you will, and a reprioritization of what's important. What are we truly trying to do here in our country? And I would contend that it's to create health and to keep people out of those high-cost procedures, out of those high-cost emergency rooms, and out of the high-cost hospitals. And in fact, you know, I talk with my patients and others all the time. None of us want to really be in an ER or an OR. Not that we can't be there if on occasion we need to be there. That's exactly what they're there for. But it shouldn't be a default, because we can't have a system that keeps us away from those and keeps us healthy, keeps us functioning, keeps us preventively well. So that's the real challenge here, is to kind of, if you will, aim that fire hose away from the high-cost items and move that fire hose into health and wellness and keeping people healthy and away from those things.
What stopped us from changing the way we reimburse physicians, for example, to give them more money for sitting down with the patient and talking to them about prevention? Because that's not generally reimbursed.
No.
Or they're not necessarily reimbursed for responding to that email or going to, you know, sending information to that. That's not reimbursed. How do we make that shift, and what's stopping us?
Yeah. How we got there was that when Medicare was set up in the mid-1960s, it started to prioritize procedures and doing things to people. It started to prioritize time and intensity of effort for high-cost things. And so the payment system started to support those items. We got off track, if you will, right at the inception of Medicare, in terms of how we prioritized what we were going to pay for. So again, pennies on the dollar on the front end of prevention and wellness, tens of thousands to hundreds of thousands of dollars on the back end in terms of doing things, high-cost hospitalization. So what it's going to take to kind of get us back on track is, again, a reprioritization of the value of what it is we're trying to do. So Medicare is the key piece here. That's why the Affordable Care Act became such a big deal in terms of Medicare. It's the federal program. It's where most of the money is spent in healthcare. So the reprioritization of the codes in terms of what the payments go to needs to be reprioritized.
As a patient, that's the frustrating. I was given the code for a procedure because I wanted to compare costs.
Yes.
And it was almost impossible to go from Apple. It was because you'd call one place and they'd say, well, that's not the right code, or this was the... It became impossible for me to shop as a consumer for better health care.
Absolutely.
Is that part of the stuff that needs to be fixed?
It is. You know, the transparency of that is bewildering, quite frankly. And it is to me as a physician. I don't know most of those code costs either. And if you're trying to find them as a patient or as a family member to try to see what it might be that your loved one is facing in terms of cost, good luck. And those things are kind of hidden and they're murky. And they're murky because they're multiple variations. In other words, you may have a procedure, but again, if it goes extra long or if there's a complication, then there are other subtleties to it, then that code isn't one fixed cost. And so it's a moving target. It's almost like going into a store to buy something, and the cost can shift based on either time of day or the circumstances around the purchase. And so you don't get one clear price, and it's a moving target on the price. And what we've come to value as being the higher cost items, of course, are those things that are procedurally oriented, as opposed to those things that are wellness, chronic disease management oriented, or preventive in nature.
Some of what you argue is that we need to change the way medical schools teach doctors. What changes would you like to see?
Yeah, I'd like to see medical schools really focus on bringing very bright, gifted men and women into medical school that are more holistic thinkers. What we tend to do is we tend to really go after people that are very bright, have high IQs, not necessarily the best in terms of EQs. And so they are very good at facts and figures and memorization and algorithms. But then when it comes to applying that knowledge in terms of seeing the big picture, if you will, what does it mean to this patient in the context of their illness or the context of their job, and able to weave that into what is the best thing for the patient in regards to what they want, the communication abilities to make sure that that's clear, we really struggle with that. And so we get a lot of really bright kids that become outstanding physicians, but with very narrow focuses. It's almost like looking at a forest. Instead of seeing that forest, what we see are a lot of trees. And in fact, depending on your specialty or your subspecialty, not only do we see a lot of trees, we see a lot of bark on trees and fissures in the bark on trees, and fungi and bacteria in the fissures on the bark on the trees. And what we need to do is holistically integrate. What I've come to see this as is that the left brain really kind of specializes, if you will, in facts and figures. The right part of our brains kind of brings the context. And what we tend to do is we tend to focus on really left brain thinkers. And what we need to do is focus on whole brain thinkers. And so it's kind of a culture shift in medical school. The other thing that happens in medical schools, and it really hurts our nation as a whole, is that medical schools are very good at graduating graduates that will help prop up kind of that high-end subspecialty type of esoteric offerings that medical schools do. High-end procedures, high-end surgeries, high-end research. But what medical schools are failing to recognize is, what about the rest of the community? What about the rest of the state? What about the small rural and urban underserved areas that need to have physicians? And so we tend to, in medical school, create exactly what medical schools do, and that's these high-end procedures, high-end imaging, X-ray, and research. And we tend not to produce the types of physicians, family physicians, general internists, general pediatricians, the primary care physicians that are so indispensable to communities' health.
It's a 70-30 split, you said, and that 70% of medical students are going into very specialized high-end medicine and 30% going into that general community family practice.
Joan,
that's scary that the balance is so far. They don't need a law to change that. Can't medical schools just make that change?
Yeah, that's a great question, you know, and not only is it 70-30 right now while I'm talking with you, but if you take a look at the last 10 years of graduates from medical schools, it's 90% that are going into those high-end subspecialties, 10% into primary care. So actually the out-of-balance nature of this is getting worse. And to your question about, if you will, medical schools' responsibilities, I've talked with the senior leadership of the American Association of Medical Colleges, And they said it's not our role to tell a medical student what type of physician to be. That's their choice. The problem is there needs to be some accountability then to the nation as a whole for a system that's out of balance. And what we've never had in this nation is some sort of strategy on some sort of balanced workforce. In the Affordable Care Act, there was actually a provision to create a committee to start to look at the national strategy for what should be the makeup of our healthcare system, be it physicians, nurses, dentists, physical therapists, pharmacists, etc. But once the bill got passed, that provision got defunded. And so even to this date, we still have no workforce committee. We have no strategy. It's a total free-for-all in the system. And so what tends to happen with young medical students is they accumulate a lot of debt. They take a look at income earning differentials, and they're making choices based on finances as opposed to on social conscience or what the community basically needs. And so that's part of why we're fractured, is we've produced an out-of-balance, off-track healthcare system that follows where the money is as opposed to what the social needs are and what the people need.
You argue, in addition to the committee, that we need to change the financial incentives if the money is going for those high-end procedures instead of the more face-to-face care, that we need to flip that finances. Again, we're back to the money part.
Absolutely. And you know, I contend that there's more than enough money in the system. In fact, in that $2.6 trillion system, which is, by the way, the largest economic sector in the entire American economy, that needs to be downsized. There's enough money in the system for everybody to do reasonably well. What we need to do is not only drop the cost of the entire system, but reprioritize where in the system it is that money is going so that we can get to better outcomes. Again, what this should be about is maximizing patients' outcomes, their health, their wellness. This shouldn't be a system to prop up doctor salaries or hospital salaries or pharmaceutical salaries or medical device manufacturer salaries. This should be about giving health to the people of our nation.
The vested interests spend a lot of money to make sure that the system stays the way it is.
It sure does.
They benefit from it.
In fact, I would tell you that our system, which costs $2.6 trillion a year, what I've come to recognize in trying to advocate for these changes is that there are 2.6 trillion reasons why not to change it and keep the status quo just as it is. And in fact, in some ways, Joan, what we've created is not a healthcare system, but a wealth care system in the sense of, indeed, providing a lot of great incomes for a lot of people. Now, I'm not here to try to bash either physicians or hospitals or any of those sorts of groups, but what it is that we have to refocus on is what we're doing this for in the first place, and that's the patients in our communities. It's after their best interest that we should be doing this. If we have a system that's producing 1.5 million bankruptcies a year, one every 30 seconds in our nation, leading cause of bankruptcies of all sorts in our nation, we're causing employers to send jobs overseas because they can't afford health insurance. We're causing states to go bankrupt on their Medicaid budgets. We're causing our nation to go bankrupt on our health care expenses. We're off track.
40%, they say, of the costs that you will spend in your lifetime on medical care happen in the last 2 years of your life. Is there something we need to do to focus on that end-of-life care?
Absolutely right. Thank you for bringing that up. The importance, I think, of end of life is critical to not only a dignified death for people, but helping to dial in and control healthcare costs. It starts with a relationship between a physician and his patient in a way in which that dialogue, that conversation can happen. What I have found in 32 years of being a family physician is that a lot of people want that conversation, but physicians are either uncomfortable, too busy to have it, family members don't think about it, all of a sudden mom or dad are in dire straits, and of course it's very awkward then to decide to either do something or not do something. Those conversations need to happen well before the end of life, probably in the last 5 to 10 years of life when the patient is still very functional, and it needs to be dialed in around what does your death look like to you? What would you like? What are the things that you want to make sure either happen or don't happen? That dialogue needs to be known by the family. It needs to be put in the form of advance directives and a living will, so that the family doctor, let's say me in this circumstance, can deal with my patient in a way that is absolutely honoring what they want. Let me just give you a specific example. My mother unfortunately died last October. She had metastatic non-Hodgkin's lymphoma. My mom absolutely had a tremendous number of things done to her. But one thing she was really clear on, as was I with her, is the type of death she wanted at the end of life. And what we had talked about was that she would come into my house, our family would care for her, she would be kept as pain-free as possible, she would be surrounded by people who loved her, she'd be kept dry and warm and as anxiety-free as possible, and she'd have a good death. That's exactly what happened to my mom. I think that I'm very grateful, looking back now 5-6 months after her death, that I was able to be with her and to help her with the type of death that she wanted. I would hope that across our nation, for all the families out there, that those sorts of dialogues, those sorts of conversations can happen in a way that honors and dignifies a loved one's end of life. And I can tell you, just now taking a look at the cost end of that, if the system does not know what the patient wants, it defaults, Joan, to doing everything possible for people. One, because you get paid to do that, and two, you don't want to get sued. So what tends to happen, as opposed to those upfront preventive conversations in terms of getting that straight, is a default system, again, to doing things. And again, that's when all the costs really start to rack up.
But people have such a hard time discussing this. Are doctors trained to discuss death?
Yeah, that's a great question. Probably not as well as we should be. We tend to be trained on disease and sickness, and again, not so much on the patient. We tend to be trained to do things to people, not to talk with them about letting go. And in many ways, physicians almost look at a death as a failure, as opposed to a natural conclusion of a very normal life. And so I think that's why earlier in our conversation we were talking about the skill set of physicians in the future. Some of the EQ aspects, as opposed
that's the emotional quotient.
Yes, exactly.
IQ. Yeah.
Yes, thank you for that. Part of the emotional intelligence we're looking for in physicians in the future is that ability to relate, is that ability to communicate, is the ability to transmit caring in a way that trust develops, so that you and I, or the patient and I, can have that kind of conversation and get to a very comfortable place around what the end will start to be.
But can you really teach EQ,
yes,
the emotional quotient?
Well, that's a good question. I think you can, through one, seeing it role modeled, and two, having experience with it. I found that in my own personal practice, that became easier for me over time, and especially if I'm watched and mentored by more seasoned physicians that helped me get to that point, just like I can do for my residents now, and to be given permission by the medical system, if you will, that is okay to do. Our country started to have that dialogue around end of life, and as you may remember, when the health care bills were being looked at, this got very quickly branded as death panels. And the nation had a real reaction to that, mainly because of the way it was spun. Somehow it was seen as, we're pulling the plug on Granny. We're not going to pay for things. And that wasn't it at all. What this was all about was a payment for a very important discussion to happen so that it could happen. Right now, it's very hard to have a particular payment code, back to the codes again, around an end-of-life discussion. And that should be something that's absolutely incentivized in our system, so that that can be right. Because in my mom's case, by having her be with me, as opposed into an ICU for those last weeks of her life, which would have cost, again, the healthcare system large sums of money, it was something that, one, she wanted, two, save the system money, three, she didn't need that kind of care. And so, again, I think that it's really important to not only train for that, to teach for that, to role model for that, but to have our nation also start to become more comfortable with that. We struggle with that as a nation.
Change the subject from something very serious, something that is more technology, integrated electronic record-keeping system. Now, there's been some move to help improve medical records, but we're not there yet. Where do we need to get with the medical records?
Yeah, I'm glad you brought that up.
It's kind of the backdoor stuff, but it's got to happen.
It really does. What an EMR does, an electronic medical record does in a practice, is it integrates data and information. So just like the patient-centered medical home integrates how the practice works, the electronic medical record starts to integrate within the practice how data flows. One, it's legible. Two, it starts to be able to pull data so that you can take a look at kind of a pattern with not only how your patient is doing, but also how a cluster or a group of patients in your practice is doing. It's absolutely critical. The big part of what is kind of becoming a problem for us in our development and usage of EMRs in our nation is that we've struggled to pay for EMRs, if you will. So many physicians who have been trained on using paper records say, wait a minute, I'm not going to do this. It's going to cost me $75,000 to bring in an electronic medical record. I've got 10 years of practice life. Why should I do that? Are there incentives for me to do that? And actually the ERA stimulus bill, the accountable, no, not the accountable, but
the stimulus bill,
the stimulus,
the way back when.
Yeah, the American Recovery and Reinvention Act, or whatever it was, I'm sorry. But the ERA bill actually had a provision in there for electronic medical records. And it was kind of a very bold step by our nation to start to incentivize the utilization of electronic medical records into healthcare. We're getting there, and we will get there. All the residents in our program, for instance, are very facile on EMRs, and that will be the future. And so we need to continue both those efforts. Where we're bogged down with electronic medical record, quite frankly, is the ability for them to talk to each other. So even though the internet is just there and we all are on it and, we're going, geez, information is flowing very easily, it's still very hard for doctors' offices to talk to each other, for offices to talk to the emergency room or to the hospital, or for a practice in Florida to talk one in Idaho about a patient that's now down there. And so I use a story in the book. Abraham Lincoln, 1861, helped integrate the railroad system. At that time, we had 3 gauges of rail track. And so we had 3 different types of trains going on 3 different locations. And what he was able to do is standardize to a 48-inch gauge rail track so that all of a sudden America became interoperable, if you will, in terms of its rail travel. And it just opened up our whole country. We're not quite there. And one role, quite frankly, of the federal government is to set some sort of standard so that we can start the interoperability of communication with electronic medical records. So we're getting closer to that, Joan. Everybody sees the possibilities and the potential, but we quite haven't realized it yet.
And there's still concern about patient privacy in those records. I think that's the big bugaboo everybody's concerned about. If they have everything interconnected, how do I know that my records are safe?
Correct. Yeah. And so there are laws to make sure that the HIPAA protection is there.
We all sign them when we go to the doctor.
Yeah, we do. And so that encrypted information is kept in a way that allows privacy. And I think that it's just kind of all of us becoming more comfortable with electronic utilization of data. I know that, just in both of our lives right now, we use encrypted data all the time with bank systems and finance systems, and we seem to be pretty comfortable with the privacy and the confidentiality of that. And it seems like we just haven't quite closed the loop in terms of our healthcare systems yet, in terms of the electronic medical record.
You argue in your book that healthcare is a basic right. So let me ask you about that now.
Yes.
Is healthcare a right and not a privilege?
Yeah, that's a great question. And I know there are people that are really divided on this. And in fact, our nation seems to be divided on that issue. I personally believe it is. I think as I take a look at our nation, there are 2 things that I think all people should be guaranteed basic rights for. One is a K-12 education. The second is basic health care. The reason I say that is that it allows, both of those things allow people to grow and to reach their maximum potential. If you're sick, you're growing up with asthma, you're growing up with medical problems, you can truly never reach your full potential. And so if you can't get that care because your family can't afford it or you live in a place that you can't access it, then it's a real disadvantage to those particular people. What I see is that there's a very social division in who gets good education and who gets good health care. And it tracks along socioeconomic lines. And so what we've created in America is a bit of a have and have not system. Those that have good education and have good health care, they raise up in the system and get the good jobs. And those people who struggle with basic education or basic health care tend to not have all of the advantages. So this becomes almost a social equality issue and a social justice issue to me. So I see health care as I do education. Those two things should be assured at a basic level. Now, in education, if you want to go and play in the band or play on the football team, there may well be additional costs. Same with health care. After the basic package, if you want to get all the fancy bells and whistles for health care, you can certainly get that as well. For instance, basic health care doesn't cover cosmetic surgeries or things like that, but certainly people should be afforded that if they want. But what I'm talking about in terms of basic health care as a right is the basic access to primary care, immunizations, timely well-child exams. A physician who cares for your family can handle you in a timely way for illnesses that you might get, starts to work with you around behavioral issues that might develop, starts to deal with mental health issues early. So all of those things start to maximize a person's potential. And so to me, in my way of thinking, that becomes a basic right. When you get outside of our country and you take a look at the other industrialized countries, they look at health care as a basic individual right. What they've been able to do better than us is norm around society's well-being in terms of the whole being healthy versus the individual. What we struggle with in this country is the individual rights to choose. And so that plays out with health care around, hey, that's an individual's decision. It's an individual's ability to either get or not. I've got mine, now you get yours. And that tends to be the way we look at it. And what I'd like to see us do as a nation is take this higher overarching view of this, which is that if we can provide everybody with great education and great health care, we're maximizing the potential of our country by making sure that not only does everybody get a fair shot, but that our country is structured in a way that looks after itself. And that's why this becomes a big issue for me.
You only have about 20 seconds or so left to go.
Okay.
As people start hearing all the stuff that's going to come out through the rest of the year, through all the campaigns, what one thing should they remember when they hear the debate about health care? What's important to focus on?
Wow, what a question. I would say that we must get to a system that's focused on prevention and wellness versus on chronic disease and sickness.
Thank you, Doctor. I appreciate we have run out of time. I'd also like to encourage people to tune into our Web Extra program. You'll find that at idahoptv.org. And before we go, I'd like to make sure we thank the crew. I don't have a chance to do that. You'll see their name in the credits. They're a wonderful bunch of people to work with. And I also want to thank you for the years of watching and joining me here on Dialogue. I also invite you to become a friend on Facebook and join us on Twitter. And we'll see you next time on Dialogue.
Presentation of Dialogue on Idaho Public Television is made possible through the generous support of the Laura Moore Cunningham Foundation, committed to fulfilling the Moore family's legacy of building the great state of Idaho. Check out our website, become a friend on Facebook, or follow us on Twitter.